Hello, my name is Eri Beltran and today I am going to talk about is case 16-2020, a 14-17 years old woman with recurrent melanoma and pulmonary nodules. Presentation of the case. An asymptomatic 40-17 years old woman with a history of recurrent melanoma presented in the hospital after a routine quarterly surveillance image. Before after resection of right axillary melanoma and radiation therapy. Review new hilar and mediastinal lymphadenopathy and new lung nodules.
In this video, we're going to look at melanoma. This is an overview of melanoma, an introduction. Melanoma is cancer of the skin. Melanoma has the highest mortality rate of all dermatological cancers. Melanoma is also one of the most common cancers in young adults. So what are some risk factors for developing melanoma? Well, some common risk factors include having a family history of melanoma, having a personal history, having light hair color, light eye color, having a high freckle density, being immunosuppressed either because of the use of drugs or having a particular disease, and having multiple melanocytic nevi, essentially multiple moles. So how does melanoma look like? Well, melanoma looks different in each individual. So let's zoom into this person's face. And here's a cross-section of a skin with melanoma. Let us compare this to a normal skin cross-section. The top layer of our skin is known as the epidermis. Below the epidermis is a layer called the dermis. Below the dermis is another layer known as the hypodermis, which contains subcutaneous fat, which is important for thermoregulation. As I mentioned, melanoma is different in each individual. However, melanoma is usually always pigmented. It's a pigmented lesion, it's often asymmetric, it has ill-defined borders, and melanoma often bleeds or ulcerates. So how does melanoma develop? Well, let us zoom into the epidermal layer of the normal skin and compare it to the epidermal layer of a skin with melanoma. We are now looking at the pathology of melanoma. So here are some cells that make up the epidermis. Here again is our epidermal layer, and below the epidermis is our dermis. In between the epidermis and the dermis is our basement membrane. Essentially, this is what separates the epidermis to the dermis. Just above the basement membrane, we have a special cell of the skin known as melanocyte. Melanocytes are important for us because they help protect us from UV radiation, and they help in our skin pigmentation. In melanoma, what happens is we have proliferating melanocytes. So these melanocytes that are normally harmless become mutated and they grow and divide rapidly, resulting in melanoma. These risk factors can lead to these proliferating melanocytes. When going to a doctor and if suspected of having melanoma, it is important to examine the skin lesion. A good way to examine the skin lesion is to follow the ABCDE rule. So in A, we look for asymmetry. In B, we look for ill-defined borders. In C, we look for any color changes or even bleeding. In D, we check for the diameter and possibly the depth. And E, possibly the most important, is we look at elevation and in particular evolution. So if the skin lesion changes quickly or rapidly in a short duration, melanoma is suspected. There are ways to prevent melanoma. These include wearing a hat, using sunscreen, wearing long-sleeved shirts, protective clothing, especially if you work outside a lot, wearing sunglasses, and also if you have a family or personal history of melanoma, having regular doctor skin checks or even self-skin checks. So that was an overview of melanoma. Thank you for watching.
Application. Was health professionals raise the apps and are capable of responding? The population must be educated in this field. To voice on exposure and teach how to protect it. We also train the population on how to carry out self-examination and to recognize worrying signs of sunspan.
If you have a recurrence of melanoma, we can rescue you from your recurrence and you have the same overall survival than if we would have done surgery up front. And we're potentially sparing about 80% of people from this additional operation and its adherent side effects. So yes, it's great news for patients, quite anxiety-provoking until we have really good data and it's mainstream therapy. But to save 80% of people from an operation, I think is a win for patients.
Pros and cons. Pros. Removing the mole or the area affected by melanoma may be enough, or you may need treatment with radiation therapy or chemotherapy if the melanoma has affected all the organs.
Well, this is a 46-year-old woman who was diagnosed with a stage 3C melanoma now about a year ago, initially with a deep ulcerated primary and multiple involved lymph nodes. She underwent wide local excision and completion lymph node dissection and appeared to be clear of disease. Her choice was not to pursue adjuvant therapy after surgery, and unfortunately, approximately 6 months after completion surgery, she had the development of abdominal pain, and subsequent imaging showed multiple masses in the liver at more than 1 centimeters, scattered pulmonary nodules, as well as some enlarged lymph nodes, thus showing signs of stage 4 metastatic disease. She underwent a tumor biopsy, which did document melanoma, and mutational analysis showed BRAF V600E mutation being present. The question then is what to do going forward. This patient elected to start on BRAF and MEK inhibition with dabrafenib and trametinib. Management of patients with stage 3 melanoma is really undergoing a paradigm shift. I think all doctors agree, and the NCCN recommends intermittent follow-up and consideration of radiologic imaging to assess for recurrence of disease. So generally speaking, that's on the order of every 3 to 6 months or so. The question of what to do in the adjuvant space in terms of treatment is quite fraught. So historically, interferon alpha was considered a standard of care, though the overall survival benefit of that therapy was quite modest. Therefore, and a lot of doctors really advocated for observation only for patients even with stage 3 melanoma. We now know, based on the EORTC 071 data, that there's an advantage in terms of overall survival for ipilimumab at 10 milligrams per kilogram in the adjuvant space. That is also controversial, however, given the high toxicity profile of ipilimumab. And then there's an evolving paradigm of clinical trials that we'll be reporting out in the next 2 years, looking at BRAF inhibitors, looking at PD-1 antibodies, even looking at the combination of ipilimumab and nivolumab in the adjuvant setting. So this is a wide open space that's subject to a lot of physician discretion, but generally speaking, we see patients at least every 3 months, and we consider whether or not to give them ipilimumab or interferon. Patients who appear to have symptoms consistent with a recurrence or radiologic imaging that suggest a recurrence of melanoma really should be thoroughly worked up. And I would advocate that unless the recurrence is in the exact site of where the primary lesion was or in the exact lymph node basin where lymph nodes were resected, really a biopsy should be pursued. And in melanoma, now the standard of care really should be a core needle biopsy, because we need that tissue then to do subsequent analyses. Most importantly would be mutational analysis. So assessing for the presence or absence of a V600 BRAF mutation is really an essential part of the care of all patients with melanoma. There's even evolving data suggesting we should also be testing for NRAS mutation, with drugs being being developed in that space. And then further, there's a debate about whether or not we should be testing patients' tumors for PDL1, programmed death ligand 1, to direct immunotherapy treatments. That's controversial, but it does, again, emphasizes the need to get a good quality biopsy to better direct the subsequent workup. Once that's in place and you have adequate immunohistochemical stains and histologies that prove a diagnosis of melanoma, then move on to consideration of therapy, whether it be local therapy in terms of surgery or radiation, or more likely a systemic approach, again, targeted therapies towards BRAF or immunotherapies.
Cons. Recurrent melanoma can develop in the same area of the skin where it first started, sometimes even on the same scar from the tumor when it was removed. It may also appear in distant areas or in organs such as the lungs, bones, liver, or brain.
There's been a series of people that are blood relatives that have all developed melanoma. And what that suggests to us as genetics specialists is that there's possibly something running in your family. There's a mutation that has happened in a certain important gene in your DNA that is being passed on from generation to generation. And now, believe it or not, there are certain technologies that we can take advantage of to see if you are carrying at least one of those particular genes. And the gene that I'm talking about is called P16, or cyclin-dependent kinase inhibitor 2A. There's a lot of fancy terms about it. I'll just call it P16 for convenience.
Problem applied in Ecuador. In Ecuador, the information of cutaneous melanoma is rare, and there are no current epidemiological data. The highest incidence of snow melanoma, the skin cancer, is very notable in localities that are at sea level. This is because the race will sign.
With fair hair and fair skin, Pat Pinner knew he faced a better-than-fair risk for skin cancer.
One day I found something that didn't look right, and I thought that it made sense to go get it checked out.
A multicolored mole with an irregular texture and shape concerned him enough to visit the doctor.
It was on my right calf, and it had all the things they say you need to look for.
A biopsy revealed the worst. It was not only cancer, but melanoma, the most dangerous form of skin cancer.
Despite all the things that I saw and all the warnings, I still believed that he would tell me it was nothing.
It's not what he wanted to hear, but oncologist Frank Rodriguez says it may have been his lucky day.
If melanoma gets picked up early, usually a surgery is all you need. However, as the melanoma grows, then the chances that it will infiltrate surrounding tissues or even spread to the lymph nodes or even beyond the lymph nodes to other organs goes up.
Pat underwent a radical resection, which meant going back to the site where the mole was and taking out a wider margin of tissue
To make sure that there's nothing left behind. Now, depending on how deep it is, you may be done at that point, but most people would recommend getting what's called a sentinel lymph node, which is the lymph node or the part of the immune system that most likely drains the cells that came from that part of the skin.
Pat had the sentinel node removed and checked for cancer. The result was negative. In the 10 years since, there's been no recurrence. He considers his doctors lifesavers.
I was fortunate to be able to have them diagnose this at an early stage and to take care of it, and now it's not an issue.
So melanoma is a bad disease, and it's one that you can really modify the outcomes if you just find it early.
Recognizing it quickly and treating it properly can prevent a mole from becoming a mountain. For Lee Memorial Health System, I'm Amy Osher.
Conclusion. In conclusion, the patient with the antecedents of recurrent melanoma presented pulmonary nodules by means of the routine quarterly surveillance image, which diagnosed histoplasmosis as it is discussed by the inhalation of the spores of that fungus that is often found in the drooping of the bears and of the birds.